My name is Gabrielle de la Gueriniere, and this is my colleague Maureen McDonald. Maureen is from Task, Illinois. I'm with Legal Action Center, and we're very happy again to talk with you here today. We're going to kind of tag team. I'm going to talk a little bit about the ACA and some kind of key developments and things that we think are of particular importance to the criminal justice system. And Maureen's going to talk kind of on the ground, practically, how the ACA really impacts your program. So we're leaving a bunch of time at the end for questions, but if there's any kind of real burning question, you can feel free to jump in. So just a little bit about my organization. We're a nonprofit law and policy organization. We've been around for about 40 years, and we're based in New York, and we have a small office in DC where I work. And all of our focus is trying to expand services and opportunities for people with criminal records, people with addiction histories, and people with HIV and AIDS, and also to eliminate discrimination in policy against our constituencies. So we're going to try to highlight, we know healthcare reform is this huge, mammoth, complex, challenging topic, but we're going to try to highlight some of the key pieces we think are of particular importance for you and the folks you serve. So I'm going to be talking about two kind of big buckets: how the federal healthcare law expands coverage and how it expands access, and what some of the key issues are in each of those areas. So we'll talk through how the law seeks to expand public insurance through the Medicaid expansion, and also private insurance through the establishment of health insurance exchanges around the country. I'll talk a little bit about the essential health benefit process, which is the core group of services that have to be provided in each of the plans that the ACA oversees, and also a little bit about the eligibility and enrollment work that's happening around the country to start to get people enrolled in insurance. And after each of those sections, I'll talk a little bit about kind of your role in the states, because it's obviously so much of the activity is happening in your locality, in your state, and your counties. And it's extremely important for all of us to continue to be educated and informed about all of this so we can weigh in as decisions are being made. So I'll start with Medicaid and what the law does to expand Medicaid eligibility. So as I mentioned, this really is, I know they talk about it as a healthcare reform law. This is really a health insurance law, as we all know. So a huge piece of what the law does is to expand public insurance through Medicaid, both by lowering the amount of money, the income requirements, and also removing a number of the categorical restrictions that the program has had attached to it. So there will be an expansion, and I'll talk, I know, in not all of the states right now. We're going to talk a little bit through that in a moment. But an expansion to everyone below 133% of federal poverty. And the key thing here is that as I'm sure many of you know, childless adults, no matter how poor they are, in many states have not been able to be covered through Medicaid. So this is really a significant opportunity. This is something that we think for criminal justice involved folks who are not parents, this is a huge opportunity to get covered for the first time for many of them. A huge carrot that comes with this, as we all know, is very enhanced federal funding. Starting in 2014, it will be a 100% funding from the federal government to cover this population, and it'll go down steadily until it stays at 90% in perpetuity. So again, a huge amount of federal dollars that are going to be provided to help care for this population. As we all know, the Supreme Court, when they ruled, they did make it optional for states to move forward with the Medicaid expansion. And this is kind of a snapshot. I was telling Maureen that this is as of yesterday. We know that the states are starting to realize that the decision-making needs to happen soon, that 2014 is really very close to where we are. So this is kind of the state of things. There are 14 governors who have said we don't have plans to expand and move forward with the Medicaid expansion. There are 2 that are leaning toward not expanding, and now there are 24 states plus the District of Columbia that have announced their intention to expand their Medicaid population. So again, we see here that the federal money is a huge, huge carrot for states who are considering this, and we do, I think, expect to continue seeing states move in this direction to expand Medicaid. So there is a time limit here. I just want to kind of highlight this. Some folks have asked, if states decide to expand their Medicaid a few years down the line, will they get that 100% for the first few years? And it's not that way, unfortunately. Again, going back to the previous slide. So from 2014 to 2016, again, it's 100%, and then it does go down after that, but staying at 90% of federal funding for that. So just talking a little bit about the benefits that will be provided to the Medicaid expansion population, there is a benchmarking process where states are going to consider different plans that are in their states and look at those benefit lists to then extend that benefit list to their expansion population. And they can choose between the Blue Cross Blue Shield plan in the Federal Employee Health Benefit Program. I'm sorry for all the acronyms in this slide, but I will define them as we're going, as I look and see all of those awful big letters. So the first is Blue Cross Blue Shield in the Federal Employee Health Benefit Plan, a state employee plan, the largest health maintenance organization in the state, a benchmark equivalent that already exists, or secretary approved coverage, which is the federal Secretary of Health and Human Services who could sign off on a benefit package. Some states have already announced their intention that they do want to use their benefit package that they're using for their traditional Medicaid beneficiaries and extend that. So that would fall under the secretary approved coverage option. So here, again, states have a lot of flexibility. They have a lot of decisions to make, and states do, I think, the federal government is trying to work with states to give them as much flexibility as possible in a number of areas. It is possible to do a few different benchmark plans that are targeted toward different populations. So that's one thing we're not sure kind of what the states will do with that, if they will have multiple benchmark plans that they run or whether there will just be kind of one for this expansion population. But I did want to mention I'm going to talk in a few minutes about the different benefit requirements that the Affordable Care Act establishes. And one is that there are 10 benefit categories called the essential health benefits that must be provided to all of these different plans, and I'll talk more about that. But we do a lot of work on addiction and mental health issues, and one thing to note here is that regardless of which plan is chosen to be the benchmark for the Medicaid expansion population, those 10 categories of benefit must be provided. And one of those categories is mental health and substance use disorder benefits. So again, for the Medicaid expansion population, folks must have coverage for mental health and substance use disorders, and it has to be provided in no more restrictive way or at parity with other medical and surgical benefits that are provided. So some specific considerations on Medicaid for the criminal justice involved population. As you all know, currently federal Medicaid reimbursement cannot happen for care that's provided in jail or in prison, and that does not change. The law does not change that. So just wanted to emphasize that. However, there is, and I will happily answer your question in 2 seconds. There is so Medicaid enrollment, though, is extremely important, and there are a couple of different reasons. There are a number, we would argue many different reasons why this is very important. But the first is that the policy arguments, we obviously think that people before they're incarcerated should be enrolled in Medicaid, so care that's provided in the community upon their release. So there's continuity of care, which we know also has a direct impact on recidivism back into the system. We want people to be able to get care, and we don't want any kind of time lapse in between someone coming back into the community and being able to access care. There also is a provision of the law right now that allows for federal Medicaid dollars to go for care that's provided outside, even for an incarcerated person who receives care outside in either a hospital or a nursing facility, a juvenile psychiatric facility, or an intermediate care facility. Under those instances, federal Medicaid dollars can pay for that care. If a person is enrolled in Medicaid and their eligibility is suspended while they're incarcerated, then federal dollars can be collected for those services that are provided, again, outside of the jail or prison setting. And I'm going to go to your question.
My question is, technically, someone who's incarcerated, is it someone that's been convicted and sentenced to incarceration, or is it somebody that's just in the jail while the case is pending?
I'm focused on people who are in jail or prison who has been convicted and has been sentenced.
Okay.
Yeah.
But at this time, it also applies to people that are pre-adjudicated.
Right. Right.
And if I may, my question for you is, the way you stated that, it sounded like federal dollars could be used for all off-site services, whereas currently, at least in Arizona, we can only use it if they're inpatient.
So the question was, and yes, so the question,
is that changing?
No, that part of it. So it is an inpatient. It has to be more than 24 hours stay in one of the settings I mentioned for those federal dollars. So that does not change. That's right. So yes.
I'm just confused. So the pretrial who are in jail will not be eligible.
This is an area in the Affordable Care Act. The law isn't entirely clear. There are regulations that are needed to clarify this because it's not entirely sure what the intention is. The way we're doing planning right now is assuming that the restrictions stay as they are, and that if there is some opening for services to be paid for in a jail or prison setting, then we'll deal with that later, because there's plenty to do just with service expansion in the community. But I don't know what's going to happen in terms of clarifying that. I personally don't see CMS changing their policy, but I don't know.
I guess I'm sorry for the confusion, but with the inmate exclusion, does that mean that if we have a prisoner in our jail and he goes, say, to our local FQHC, we take him there, that the jail could be reimbursed for that?
So there are only four kind of exceptions so 4 types of facilities that are covered under the inmate exclusion. So it's hospitals, intermediate care facilities, and I'm not sure how that's defined.
But like a nursing home for stroke rehab, something.
Right, that makes sense. And a nursing facility or a juvenile psychiatric facility. So it is specific to those 4 different types of settings. And the stay does have to be over 24 hours. Yes. And this is something that is not well known, I think. I think there's been a lot of misunderstanding about this and a lot of assumption that once you go into incarceration, if you are on Medicaid, that has to be terminated. And not only is that not the case, but the federal government has repeatedly come out, to the contrary and encouraged states to suspend and counties to suspend eligibility so that care can be better covered and reimbursed. I saw a question here. Yes. Okay, so it was a question about an individual who goes out and receives care at a hospital for psychiatric services that is not an IMD. I don't think actually the law makes a distinction between that in that area. I'm not positive, but it does talk about hospital coverage or juvenile psychiatric facilities. So yes, I would say if it is a hospital, if it is not connected to the prison or jail, then care should be federally reimbursable. So next steps. I think, again, huge role for continued education at the state level, at the federal level. Again, really emphasizing for those of you who are working with folks coming out of incarceration, to emphasize how critical it is that people have health coverage that is not interrupted and people are able to get what they need when they need it. Ongoing work, we continue to find that the health and criminal justice systems need kind of bi-directional information about each other and about their different policies and how this all works, so that's extremely important. I think having all of you as ambassadors understanding that mental health and substance use disorder services must be covered for all of these folks in the same way that other diseases are covered is extremely important. And then some of the health home work, which in some of your states, they may have elected to move forward with the Medicaid Health Home Initiative, which is focused on people with 2 or more chronic illnesses. There's a heavy focus on people with mental health and substance use disorders. And we just think, I know in New York, for any of you who are in New York, that a number of the health homes are being targeted and intended to work and provide care for people who are involved in the criminal justice system. So there's a real opportunity there. So that's Medicaid. I'm going to move on to the private side. So again, the ACA expands public insurance and also private insurance by creating here health insurance exchanges in all of the states. So these are competitive state-based marketplaces. There will be small employer plans and individual plans that will be operating in these health insurance exchanges. There are subsidies that are provided to help people afford coverage. 20 million people are expected to have coverage through a plan that is in one of these health insurance exchanges. And although it's limited initially to small and individual plans, large group plans can come in 2017 if all is going well. So the plans that are operating in health insurance exchanges do have to meet a number of requirements, qualified health plan requirements, and a number of consumer protections, which I'll talk about later. As I mentioned a little while ago, the essential health benefit requirements, those 10 essential categories of benefit, which include substance use disorder and mental health benefits, must be provided by the plans operating in the health insurance exchanges. In regulations the federal government has released, they also have paid special attention to mental health and substance use disorder service providers, and there's specific language that requires that qualified health plans have to maintain a sufficient network of providers, including mental health and substance use disorder providers, to make sure that people can get care without unreasonable delay. So that's very important, and we think that's a good thing. And I'll talk a little bit on the next slide about whether states are run by, exchanges are run by the state, the federal government, or in partnership, but regardless of who's running it, and this is something important, if your state is electing to have the federal government run an exchange, all of these requirements still must be met, regardless of who is running the exchange. So we know there are three options. States can run their own exchanges, the federal government can run a state's exchange, or there are these state-federal partnerships where states can choose to do one or a couple of things. The first being consumer outreach, and the second being plan management activities. So we know that the deadline just passed last week, so I have a good update. And this is a current stat here. So 16 states and DC have elected to run their own exchanges. 7 states have elected to do a partnership between the federal government and the state, where, again, the state will either do consumer outreach activities or plan enrollment work, or both. And then 27 states have elected to let the federal government take care of this and run those exchanges. So we know that the federal government has released guidance on how each of these different models is going to work, but more is expected soon. The goal and intention is for the health insurance exchanges to all be operational starting in October, which is amazing to me that we can actually, October of this year. Again, it's kind of startling after working on all of this, that's very soon, but all of them, again, regardless of whether they're state or federally run or partnership, should be ready for open enrollment in October, and all of the coverage provisions will start in 2014. So, again, things for us to do at this point: continuing to educate your state and federal decision makers about policies that would ensure that your folks' needs are being met. It's very important. I think the outreach and education component is very important to make sure that harder to serve folks are being well brought into all of this. Making sure that there's good enforcement of the different consumer protections that are a part of the law. Making sure that the network adequacy standards that are intended to ensure that all of the different specialists are really, that there is a strong, adequately trained workforce to take care of all the people who we're hoping will get care. Making sure that coverage is easily accessible. And then we know in each state it's a little bit different. There are different types of boards and advisory committees, really making sure that those folks who are in those decision-making places know about the needs of the people you all serve. So 2 more last little buckets. How am I doing on time? Roughly?
3 more minutes.
Oh, 3 more minutes. All right, this is going to be super fast. You see all of the essential health benefit categories. They are wonderful, important services. And again, I'll just highlight that mental health and substance use disorder services must be covered. So all of these different categories of benefit, I will leave this up so you can see it for longer, must be covered by individual and small group plans in the health insurance exchanges, and also the non-grandfathered plans outside of the exchanges. They also must be covered by, again, in those new Medicaid expansion benchmark plans. And so the only folks that are the only types of plans that are not covered through the EHB requirements are large group plans and traditional Medicaid. So the specifics about the essential health benefits. As you all know, the law was 2,000 pages, but they did not define everything. They did not define many things, even though it was so lengthy. One of the things they did not define was the continuum of care that's represented in each of those 10 different benefit categories, which services need to be covered. So for mental health and substance use disorder services, we've been doing a lot of work to ensure that this is defined in a way that really helps people avoid disease, get well, and stay well. So the federal government did set up a system where a lot of these decisions are going to be made by states. And the states could choose from one of 10 different types of plans that operate in the state to benchmark, again, to that benefit list. It's similar to what I was talking about earlier on the Medicaid side, but there were more options on the commercial side. States that did not choose, this is another kind of misconception for states that didn't choose a benchmark plan for their essential health benefits. It doesn't mean that there aren't essential health benefits in that state. It just means that there was a default to the largest small group plan list in that state. So here's again the current breakdown. 28 states picked including DC, picked a benchmark plan. 23 either did not or defaulted to the largest small group plan. And then you can see the breakdown there. And I have the specifics. If any of you would like specifics about your state, I do have the list for afterward. So again, the essential health benefit must cover each of these different benefit categories. If a category is missing, if a plan is selected as a benchmark and there isn't that category, it has to be supplemented and substituted in from another plan. There also are coverage requirements that require that mental health and substance use disorder coverage, again, is on par with coverage for other diseases. So it can't be more restrictive to access those benefits than other types of medical and surgical benefits under the plan. And the key thing here is if the plan does not comply with parity, then they do have to supplement that coverage. There are also non-discrimination requirements to ensure that people are not discriminated against in terms of benefit design because of age, disability, or expected length of life. They also require that the essential health benefits address healthcare needs of diverse segments of the population. And a key thing here, again, the Secretary of Human Services at the federal level must review all of the benchmark plans, all of the state plans, to make sure that those plans comply with all of these different requirements. So next, federal steps. So the final essential health benefits rule actually was released last week. It was very consistent with the preliminary rule that had come out, but with a couple of differences. One is that there was strong language in the final essential health benefits rule that said that coverage that didn't meet mental health and substance use disorder parity requirements does have to be supplemented, and additional services would have to be added. And this is the key part, one of the key parts, that states will not be held financially responsible for supplementing and for adding those additional services. There was a lot of confusion. A number of states had looked at their benchmark plan and felt that the mental health or substance use disorder benefits were not comparable to coverage for other illnesses, and they wanted to bring it up to par, but they were worried that that would mean it was a state mandate and that they then would be on the hook financially. So the federal government did clarify that this activity is really bringing it into compliance with the different requirements of the law, and it's still federally reimbursable services. So on the Medicaid side, we have gotten some preliminary guidance on Medicaid and the essential health benefits, because as I mentioned, for Medicaid expansion plans, they must comply also with these essential health benefit requirements. We're expecting final guidance in April. We also are expecting final guidance on the mental health and Substance Use Disorder Parity Law in May. And again, just want to emphasize that there are other levels of review that the Secretary is going to be certifying this. Find out, if you don't know what is happening on in your state on EHB, find out if you need help. We are around, happy to be helpful any way we can. I think it is important, again, to do all of that. So the last thing I'll say really fast is that eligibility and enrollment is a huge, huge, huge focus in the Obama administration right now. There is a lot of work to make this as simple and as streamlined as possible and to make it as consumer friendly as possible, although we know that there are huge challenges here. I think we can all recognize that there is a lot to do to bring people into a good place to educate them about health insurance and the choices that they're going to need to make. And so I would just say to find out about activity in your state related to eligibility and enrollment, related to those programs that are intended to try to help educate consumers and get them enrolled in health insurance.
You probably noticed that as Gab was describing what's going on with implementation of health reform, there are a lot of this is what we know and this is what we don't know yet. And if you ever remember seeing a photograph or a drawing of the Eiffel Tower kind of halfway built, where it's just like up to here and it don't have the top part yet, that's about where we are. And that's why it's somewhat confusing. That's why there's a fair amount of uncertainty. But we're getting very close to at least an operating level of certainty pretty much across the board. And so I always encourage people just to hold on and work with what you know. So that's what we've been doing in the justice system in Illinois. I'm Maureen McDonnell. I'm the Director for Business and Healthcare Strategy at TASC in Illinois. We are a statewide case management agency working with people to keep them out of prison diversion work, and work with people then if they go to prison when they come out to try to keep from going back. We work with about 300 providers of substance abuse, mental health, and recovery support services across the state. And we don't provide any of those services ourselves. So we're sort of more system-focused and population-focused. And for us, when it became clear that the Affordable Care Act was a real thing back in 2010, we said, okay, this is an enormous opportunity for the justice system because there's such a concentration of people who are uninsured and people who have untreated psychiatric disorders and co-occurring substance use disorders and primary substance use disorders that are untreated that keep bringing them back, that this is like the biggest sea change we could really imagine. And so we've gone about national advocacy, we've gone about working in partnership, and we're doing a lot of implementation work in Illinois. So a lot of my examples are from Illinois. I apologize for that. But we are sort of typical of a lot of states where we don't have coverage for low-income adults until now. So I'm going to talk about what do you do, how do you think about the Affordable Care Act making a change in the justice system. The first thing to know is that there's an enormous number of the people who are going to become newly eligible who are under justice supervision. If you crunch these numbers for your own state, Jasper already did this for you, these are the Illinois numbers. We just looked at the number of people who flow through the jails in the state in a year, the number of people who are on probation in a year, the number of people who exit state prison in a year, and you could also add people on pretrial supervision, and there's other categories that are worth adding. And we came up with about 300,000 unique people in a year. And that's more than a third of the number of people who are expected to enroll in Medicaid in Illinois, depending on, all these numbers fluctuate. But the point being that this is an area of action where we can help the state and the health system meet their enrollment goals because they have to have expectation that every single eligible person get enrolled. That's part of the law and their legal compliance. And also, we know what this will mean when people actually have access to services. So when I talk to judges, this is what I say. I say, today, 1 out of every 10 people who appears in front of you has some kind of health insurance. 1 out of 10. And this is not in states like New York and Massachusetts that have already expanded coverage. This is in the rest of us. 1 out of 10 people, maybe they have veterans benefits, maybe they have disability-based Medicaid because of a mental illness or a physical disability, maybe they have some insurance through a job, but that's fairly unusual. So 1 out of 10 of the people who appear in front of you, and then you deal with programs we create and state and county funded services to get access for everybody else. And what this means in 2014, what the Affordable Care Act means, is we're moving to 9 out of 10 people who appear in front of you, Your Honor, who will have coverage. And that means you can make meaningful requirements that they get assessed for their untreated behavioral health problems, and you can reliably require that they participate in the services that are recommended because there'll be a way to pay for it. Now, it's not nearly that simple in practice, but that is the concept. And I find that the judges go, what? Like, really? How is that going to happen? And so it's been very exciting to talk about. And we're doing a system-wide planning process in Chicago right now. We may be starting in some other jurisdictions that are interested because it's like nothing that's really ever been available. So there are specific opportunities for the courts and probation, and then specific opportunities for jails. I'm going to talk about both of those briefly so we can get to some discussion. When you think about the impact of untreated psychiatric disorders and addiction, one of the things that happens the most often is probation violations that are related to those untreated problems. And so what an opportunity to substantially reduce probation violations and new arrests that are related to those conditions. And very important thing here, remember 1 in 10 to 9 out of 10, getting these results across all probationers and everyone under court supervision, not only people who are fortunate enough to benefit from our smaller demonstration programs. Now, these demonstration programs and specialty courts, I've worked on building a lot of them. They're extremely important because they've proven out the model and the concept. We've proven that it makes a difference. We've proven that it reduces jail days. We've proven that it increases quality of life and safety in the community. And now we're completely tooled to take this to the broad scale and to say that every person who has an untreated psychiatric disorder and addiction should get the benefit of these services. And it's about figuring out how to build the infrastructure to do it, and how to let the Affordable Care Act do the heavy lifting to pay for the substance abuse and mental health services. A lot of people in this room may either work in or be familiar with specialty courts, particularly probably mental health courts in this room. And we think there's a very important role for specialty courts going into the future. First of all, specialty courts themselves will benefit from better access to services and not having to constantly write grant proposals to get money for services. But we think that because it's such a labor-intensive model, that there's a really important opportunity to focus on high-risk and high-need probationers, people who really need that level of accountability to straighten out their behavior and get engaged in recovery. And so that's an important conversation within the system. You know, in a system that is going to have pretty much the resources it needs from a behavioral health perspective, then what do you do with specialty courts, which have been a gap filler in many communities, certainly in our community. So I think there's also a very important role for leadership because, you know, judges like to learn from judges, state's attorneys like to learn from state's attorneys, and we've got this workforce of people who've been in specialty courts all these years who are ready to do it. To get this done, we need to do a couple of things. One is we need to get people enrolled in Medicaid and insurance, whatever they're eligible for, in a timely manner, ideally before they leave an incarcerated setting so they can walk out of the jail and walk into treatment. From my perspective, that's the gold standard. And we also need universal screening early in the justice process so that we know as people are moving through every part of the justice system, whether they're staying in jail or whether they're going on to probation, who needs what? You know, is this person primarily a person with serious mental illness? Is this person primarily have an addiction problem? How are we going to, and that's the basis then for recommending services to them in the community. We need to be able to match them to appropriate services. So from my perspective, courts and probation are going to need to know all the services in the community and have a method for determining sort of the appropriate way to make those referrals. We're working, just as one example, we're working with Dr. Faye Taxman from George Mason University on a process that she's put together that really creates essentially a managed care type of algorithm for matching offenders to treatment and based on what will lead to the least likelihood of recidivism. And we think that's a huge innovation in this time when we're going to referring large numbers of people into care. And I would definitely recommend looking at that in the future. We're certainly going to need expanded service capacity in the community. The good news is there's money coming to pay for that. We've been convening meetings with providers to talk about how do you do that, and how will you get referrals from the justice system so they'll have some assurance that it's worth their time to make those expansions. But those services in our communities have been cut 30% over the last 5 years, so they're pretty ready to expand. And there's a workforce of people to be rehired who we think want to come back. So we also want to make sure that we have criminal justice responsive treatment, which means the need for quality and certification and training. We want agencies that are familiar dealing with the justice population to be doing this work. There will be people who will come in because there's money, come into the Medicaid expanded system. They aren't going to do well with our folks if they're not prepared, if their staff isn't prepared, if there's a lot of stigma, if they don't understand the related issues that need to be addressed, not just the person's behavioral health condition, but their lifestyle, their peers, all those criminogenic risk factors. I'm standing next to a chart that's the outcome of that work. We also think same-day access is extremely important for a justice-responsive system. If it's Friday afternoon and the alternatives are sending someone back to prison or putting them in treatment, the treatment has to be available Friday afternoon, not 3 weeks from now, because that's not going to work for a parole officer making that decision. And there needs to be a good way to report back to the supervising agency. And in Illinois, TASC does that work. There are lots of other ways that gets done, but not every treatment provider is prepared to do that or are familiar with, the rules around that. Similar opportunities in jails, and I'll go through this more quickly because it's very similar, but when you think about the numbers of people who frequently cycle through jails due to these untreated conditions, very expensive in jails, the medications are expensive, the health management is expensive, and if you have less people in jail, that's less money out of the county budget, so it's a big deal. And the potential to reduce incarceration through using these new resources in a structured way to increase diversion, like what a lot of the work at this conference is focused on, and in partnership with appropriate pretrial and probation supervision, we think is one of the biggest areas for potential benefit for counties and for people. Get people to treatment in the community, not languishing in jail when they will not largely get better in jail. And better for counties and other agencies of government who pay for those services in jails. It doesn't have to be done that way anymore. Same things are needed to gain results: rapid enrollment, universal screening, and matching to appropriate services. There does need to be some kind of infrastructure for coordinating all this. You all may be that infrastructure. It's conceivable, depending on the size of your jurisdiction. Or you may need to be sort of working on building something, that does that. Some of those services, assessment and ongoing case management, depending on how your state decides to do things in the benefit packages, can be paid for with the new Medicaid dollars, and some of them won't be. Services provided in jail, court advocacy services, things like that, probably won't be. So we're entering an era where we're going to have to braid funding from different resources to get this done. But this is what's needed to really move the broad numbers of people, into services in the community. It's very important as we do this that we avoid net widening. And net widening is kind of a term of art in the justice system that basically says, don't draw more people into the system than would have been there if you did nothing. So don't make it worse, basically. And what we want to avoid is, so imagine this scenario, right? A probation department decides to take this on full scale. Everybody's going to get referred to treatment. And then when they don't go, they're going to be subject to immediate sanctions. Well, depending on how those sanctions are structured, you could wind up putting a lot more people in jail and prison. And that would be the opposite of what we're trying to make happen. So good diversion programs like all of you, drug courts, we've worked hard to develop graduated sanctions protocols. Doug Marlowe's research in this area is very helpful in thinking about what to do when in the stage of early recovery, mid-recovery, late recovery. You do different things to get somebody's attention at those different points. And so we want to use those well. We don't want to over-respond. And so this is a very important and fruitful area for work, I think, over time, over the next few years. The rest of my slides are about the leadership role of judges, court administrators, probation chiefs in this implementation process. I'm going to kind of summarize it just so we have some time for discussion. Basically, as judges and all of these leadership partners have the capacity to convene important meetings, right? Don't people come when your chief judge calls a meeting? They do in Chicago, I can tell you that much. And the problem is, or the challenge is, that we need new partners. We need the state Medicaid authority at the table. We need the state Department of Insurance at the table. We need the health system. We need the treatment providers. We need more providers than we're used to working with. And so to be able to bring all of these people together in a structured planning process, you need a champion. And we think these are good champions from the justice system. It's also important for the justice system to say what the public safety interests are in health reform. We need benefits that are of sufficient duration. We need mental health and substance abuse treatment services that are of sufficient duration and intensity that somebody can actually get better. If it's just 4 sessions of outpatient, some people will benefit from that, but not the people who are the most expensive in the justice system and hospital emergency rooms and. So we need to make this argument that just saving money on the benefit package is very short-sighted, and the justice system is well positioned to do that. I'm just going to see if there's... so just as very briefly an example, so we are running a planning process with the leadership of our presiding judge of our felony courts in Chicago. There are we're talking about very large numbers of people, but this is equally applicable in a small community, and perhaps even more important in a small community where you've got to really leverage stuff to get things done. We have all the justice stakeholders at the table. We have an early expansion of Medicaid in Cook County under auspices of the Affordable Care Act, so our county health and hospital systems at the table, as well as a number of substance abuse, mental health, and medical providers, and we had some local community foundation funding to support it. And we're working on exactly that list of stuff that I told you about. So we've been working for 6 months on enrollment. Starting on April 1st, the county health and hospital system is going to be enrolling everyone in our jail intake. So it's going to be 40,000 people a year who are going to get enrolled in Medicaid, who are the people everyone who comes through the courts. So we've been working on that. We've also been working on the benefit plan. Their first offering, when I said 4 sessions of outpatient, that was their first offering, okay? I'm just telling you, that actually happened to me. But we have now succeeded in persuading them that state law and parity requires them to actually offer the full range of mental health and substance abuse services that are defined in state law, that are in the specialty systems, now have to be integrated in Medicaid. So we're going to be able to send people out of the justice system into residential treatment. Well, now that actually might make a difference. So these are, we're sort of learning how to put this all in place. And the Legal Action Center task and our partners at Advocates for Human Potential are also doing a project with SAMHSA that's about nationally looking at models for Medicaid enrollment in jails and prisons. So we are also, remember that Eiffel Tower halfway built, we are also trying to help shine light on what will work for lots of communities, because there's a lot to consider, there's a lot of choices, and this is a really potent and important time to work at making a difference on behalf of the people that you're already serving, and all the people that you can't get to. I mean, it's not much of a choice, and you don't really have to use evidence-based practices when you've got 200 people who need to go to treatment and you can send 10. There's no evidence-based way of triaging those people. I mean, it's a hideous choice that we're all left with. And so the best news I can leave you with, and the reason to struggle through understanding the Affordable Care Act, is you're going to be able to get to all 200. And in many communities, it's many more than that. I mean, we've got 100,000, that's just in Chicago. So I think we'll stop there and leave some time for discussion.
Well, my question has to do with the fact that I come from a state where our governors decided that we're not taking the money from Medicaid. So I guess that leaves us with the default position of the marketplaces, I suppose. Is that what happens? And then the other part of that is our county legislative body has decided to ask for the money anyway, even though the governor says we're not getting it for the whole state. Is that actually a possibility, or does the state have to get the money for any one of the individual counties to get it?
So first of all, which state are you from? Texas, yeah. So I guess first to your second question, There has been some discussion about letting certain parts of the state move forward, and the federal government has been resistant to that. But I think the federal government has been, working as hard as it can to be as flexible as it can for states to encourage states to move forward in their own way, in their own time. So at this point, that's something that hasn't happened, but we will see. I think on your first question, I'm sure you all saw that governors of Ohio and Virginia and Arizona and Florida are determining to move forward with the expansion. So I do think there does seem to be a trend toward expansion at this point. I'm not saying that that's necessarily going to be what happens with Texas, and you're correct that even without the Medicaid expansion, the private expansions are going to happen regardless of whether the state is running the show or the federal government. So I guess just continued hope that things do move in a better direction.
The one option that I'm familiar with for county-led development in this is the one that Illinois took advantage of, that actually California figured out. So if there's anyone from California here, we can't thank you enough for figuring this out. And what happens is the counties actually put up their own dollars that they spend on uncompensated care, meaning in the public hospitals, if the counties pay for substance abuse and mental health treatment that there's no other way to pay for, and put that money up for the Medicaid match. So in Cook County, that's almost $500 million that this, and I'm a county taxpayer, so I care a lot about this, that we spend on otherwise uncompensated medical care, and then the county taxpayers pay for that. And with the Medicaid match, we'll be bringing another $500 million, with a B, billion dollars into Cook County. And so that we were the second state to take this on. Ohio is the third, and Cleveland has Cleveland will benefit from it. Cleveland has an application that's about to be approved, and I know that there's been discussions about the 6 largest counties in Texas doing this. And so what I think about this is that all the states are going to come along eventually. It may just be a little while in Texas. And I think it's important for the justice system to be involved, because justice system is a huge stakeholder in this, and one that wouldn't necessarily know about it. But it's time to become part of the discussion.
Hi, my name's Lauren. I'm from Rio Arriba County in northern New Mexico. And I have a feeling that we Wyoming or Alaska are here, we're probably the most rural county participating in this program. We have that Medicaid match program that we're working on putting in place, and we have a very spotty mental health system, almost nothing available. And so we know we can't rely on our judges to display leadership in this area. If somebody's going to do it, it's going to be the county. We own the facilities. We own the facility that the residential treatment center is housed in, the facility that could become the health home, and possibly with the Medicaid match, the funding to actually finance the program. And this is all very new to us. We're not really sure how you pull something as comprehensive of this together. So any advice you could give us about how to do that is appreciated.
So I'm really glad you asked that question, because this is a challenging collaboration to pull together. And however, it's not impossible, and I think these projects that are represented in this room are examples of those kind of collaborations. So I would be happy to talk to you in a very detailed way about this after, or we can connect an email. But there are a couple of things to think about. One is just know how many people in your county are going to benefit from the Medicaid expansion and from the health insurance exchange. That information is widely available. It's based on the census, and so we can help you find some resources on that. And then it's talking about, okay, how many of those people appear in the justice system, and what service expansion are we going to need to meet their needs? We did some back of the envelope calculations. We're going to do some real ones now, but we didn't do that yet. And we think we're going to be sending another 8,000 to 12,000 people to mental health and substance abuse treatment in Chicago every year out of the justice system, possibly more than that. And that's just out of the courts. So it's possible to kind of make some estimates about this and then say, okay, well, what would we need to do? Can our existing providers expand this much? Do we need to court some new people to come in and provide these services? It doesn't all have to be done at once. It can be done in manageable stages over time. And I think if your partners aren't exactly where you want them to be yet, think about manageable stages over time. We can make some of the resources that we have on planning, we could make available to you if you want to have those for participants.
So I work with the juvenile system, and I've heard a lot today about when they come out of prison, when they come out of incarceration. And your program sounds like you're looking at 40,000 coming out of the jails and the prison system. So it just feels, I guess, the whole conversation here today just kind of feels like if our goal is to reduce people from going into prisons, we're missing a chunk. And so I'm just not hearing that covered. And if we're also going to be able to refer all these people to residentials now from prison, is that going to make like a residential boom like it did with our prison boom? And are we going to have to start building and funding new facilities?
Sure, I did focus a lot on adults, and I'm sorry about that. It's something where we anticipate the same kind of coverage expansions and hopefully the same improvements in access to care in the community for kids and adults in various systems and not. I think the role of parents obviously is something that we continue to talk about, but quality of care, we're hoping with the additional federal dollars that are coming in and that are hopefully going to be strengthening the infrastructure around the country, that is going to be something that's improved. Mm-hmm.
Yeah, and a robust set of services in the community is the best way to keep people out of jail and prison. And there's actually a paper on this that New York State has the highest per capita rate of substance abuse treatment and the lowest per capita rate of incarceration. And it's a very notable outcome. They've had this coverage for 20 years, and it's for real. It makes a huge difference. The other question that you asked was about capacity expansion. So, I think the answer is yes, and I think it's really good news. I think it's important for providers to consider what role they want to play. What I say to people basically is, how much business do you want? There are so many people with pent-up demand for these services that, if as a provider, if you want to aggressively create access, do it. The money's going to come. It's Medicaid money. It's not easy. It's not without challenges. But a lot of providers already work in Medicaid and know how to do that. So I don't think it's so much states and county governments figuring out how to build new facilities as much as it is maybe helping to catalyze the conversation and get people who are in a position to do this building interested in doing it.
Could you discuss what happens with the states that aren't doing the Medicaid expansion as to what happens between the 100 and the 133%?
Subsidies, the way the law was written, the subsidies for folks who will be in the private health insurance exchanges, there's a gap between the folks who were intended to be newly Medicaid eligible. So it is going to be a question in states that I totally agree with what Maureen said. I do think states will all end up getting there. It's just a matter of timing. In the interim, with folks who are not going to be eligible for the subsidies for the private coverage and are not in traditional Medicaid, it's going to be a question, I guess, if states are going to be putting additional dollars into systems. But it's unfortunately the law was written in a way that didn't anticipate that the Medicaid expansion was going to be optional.
If you lived on the border, your state didn't participate, and it's just you cross the border. Can an out-of-state citizen participate in the health exchange, or is that another restriction?
So the question was about border states, and this has come up in a serious way, that there are folks who live in certain parts of the country where there are going to be clear Medicaid expansion states, and states where they anticipate that the benefit coverage is going to be more robust than in other states. These are all questions about how this is going to work out. I can't answer that definitively, but I think the federal government would like to have the least amount of variability as possible. But we recognize that that's not going to be the case. And as we continue to talk, we are doing a lot of work, as Maureen was saying, as the system is being built. But for years and years to come, this is all going to be work at the state level and federally if things are not working as they were intended to work. So there are a number of challenges with that.
Just getting back to the piece on suspending benefits. Currently in incarcerated offenders, they can get suspended. If they're in for more than a year, then they get terminated. Now you're talking about them being suspended. Is that indefinitely that they're suspended? And if so, what's the reevaluation that's done with that, if any?
So the first is that different states have different policy about this. So you mentioned that in your state it's terminated for a certain amount of time. That's not something that's consistent across each of the states. So suspension policy, and it's different in different states. So I know New York suspends, not terminates. And then the second piece of your question, I totally just lost. I'm so sorry.
The second one is, well, I guess it kind of answers it, but if somebody is going to be reevaluated, like if they're suspended indefinitely, so
Right.
essentially, does that mean once they're determined to be eligible for that, they are forever eligible for it, and or is there some evaluation that later on?
Yeah. So there is a redetermination. In Illinois, it's an annual redetermination. And, if circumstances have changed, you're supposed to report that in the interim. Like, if you get a job that takes you across the threshold into the exchange, how that's going to be enforced, what the measures are, that's in the part of the Eiffel Tower that's not built yet. But it's important to, I think, to be clear on what your state's policy and practice is around suspension versus termination. And that's another really important area for justice system advocacy in the implementation of the Affordable Care Act. There are states are required to build these electronic rapid high-speed eligibility systems. And what we would like to see as advocates is that the suspension process be built into that process so that it's all electronic. County jails can provide census data into the system electronically every day. Everyone knows who should be suspended and who shouldn't be. And I've been told that states can use their federal dollars to create this eligibility system for this purpose. We're not doing it yet in Illinois. I'm hoping that we will. I'm working on that. We'll see.
Faye Taxman, is there a citation on the algorithm that she's developed or that you were working with?
I don't know of anything that's been published yet. What I can do, if you want to leave me your card, I can check with our person who's working with her and see if there's anything available. If it's not available now, it will become available. I don't know that the algorithm will be, but certainly the description of what the process is and how it works, it's fantastic. It's for me, I look at this and I think, oh, we're going to be able to operate in a managed care environment, and we're going to need to, and we're going to have this algorithm. It's going to be awesome. So, yeah.